AION is a condition characterized by damage to the optic nerve due to insufficient blood flow. Clinically, AION often presents with sudden painless vision loss, typically affecting one eye at a time. On retinal imaging, a hallmark feature is a pale and swollen optic disc, often referred to as pale disc edema. The pale disc edema in AION may be frequently associated with peripapillary and retinal hemorrhages. In AION, pale optic disc edema can present in a sectoral pattern. This characteristic often correlates with visual field defects, most notably altitudinal hemianopia, where either the upper or lower half of the visual field is affected. Anterior ischemic optic neuropathy must be carefully differentiated from papilloedema, as both conditions involve optic disc swelling. In papilloedema, the optic disc appears hyperemic, often accompanied by venous congestion, reflecting elevated intracranial pressure. In contrast, AION is marked by a pale optic disc, indicative of ischemia due to impaired blood flow. We also need to differentiate AION from neuroretinitis. Neuroretinitis is distinguished by optic disc swelling, combined with hard exudates in the macula, which often form a macular star pattern radiating from the fovea. In contrast, AION presents with optic disc swelling, but is notable for the absence of macular changes. Diabetic papillopathy and non-arteritic anterior ischemic optic neuropathy, AION, can be differentiated by their clinical presentation, visual acuity, and fluorescein angiography findings. Diabetic papillopathy is typically a transient, self-limiting optic disc swelling with minimal visual changes, often occurring in younger patients with diabetes. AION, on the other hand, is characterized by sudden and profound visual loss, optic disc swelling often with pallor, and may be accompanied by other systemic symptoms. FA can help differentiate the conditions by showing early disc hypofluorescence in AION and early hyperfluorescence in diabetic papillopathy. Angio-OCT may show decreased vessel density on the optic nerve head, and OCT may show disproportionate swelling of optic nerve. The treatment of anterior ischemic optic neuropathy varies depending on its type. For non-arteritic AION, the focus is on addressing the underlying cause, such as managing systemic vascular risk factors. In contrast, arteritic AION requires urgent intervention with pulse steroid therapy, as it is often associated with giant cell arteritis. Elevated ESR and CRP levels are key indicators of arteritic AION. In this particular case, the patient developed arteritic AION following vitrectomy surgery for retinal detachment. He was treated with high-dose intravenous methylprednisolone, which is a standard approach to manage inflammation and prevent further damage. Patients with anterior ischemic optic neuropathy require regular follow-up to monitor their condition and prevent further complications. This particular case involves a 55-year-old male patient who presented with pale disc edema and was subsequently diagnosed with AION. The patient was initiated on intravenous methylprednisolone pulse therapy. At the 1-month follow-up, there was a notable reduction in optic disc edema, and the patient demonstrated moderate visual improvement. 4 months later, the patient's left eye remained stable, while the right eye developed severe vision loss, accompanied by pale disc edema. This case underscores the critical importance of continuous follow-up and proactive treatment in managing anterior ischemic optic neuropathy.